Hello and welcome to a film review of the cervical and lumbar spine. In this presentation, we will look at radiographs of C and L spine and discuss what correct positioning should look like. So let's get started. We typically begin with our lateral C-spine. We are going to do our lateral C-spine standing at the wall bucky, but this can be performed recumbent using a horizontal beam and a cross-table method if it were a trauma situation. But in lab for checkoffs, we'll do ours standing at the wall bucky. You are going to utilize 12 by 10 portrait collimation, and we're going to use 72 inches SID. So any idea why we would need so much SID for the C-spine? Well, if you said because of all the oid, you are correct. So if you notice, because of the shoulders, there is a lot of oid between the image receptor and the cervical spine. So to decrease magnification, we increase our SID. So typically, we're going to place our central ray at C4 and mid-coronal plane. So if you notice on the picture here, C4 is right about the region of the Adam's apple. So that's a good trick to look for. And then of course, mid-coronal plane. Now, if you are correctly collimated to 12 by 10, a good trick is to make sure you have the top of your light at the top of the ear. And that will typically place your central ray very close to C4. We are going to use 20 at 73. That's nice for an average patient. Remember, that may vary depending on your patient, depending on your equipment. Okay, so how do we know we're correctly positioned? Well, when we do our spines, we always do left laterals. So position your patient with the left side against the wall bucky and use a left marker. It's really important when you're performing a lateral C-spine that the patient's shoulders are nice and relaxed. And think about it, if the shoulders are raised or, muscular or big shoulders, it can prevent us from visualizing C7T1. So you really want the shoulders relaxed. And one of the ways we accomplish that is by asking the patient to hold on to sandbags. You can also accomplish that by asking them to exhale when you make your exposure and really emphasizing the importance of relaxing those shoulders. Now, I mentioned sandbags. There is one exception to that. If your patient has any weight restrictions, you would not want to give them sandbags. So always ask your patients, especially if they're post-op, do you have any weight restrictions? And certainly if they don't, then sandbags work really well. You want to make sure that you include all 7 cervical vertebrae. So typically, I like to start at the top. Here's the base of the skull. So this is C1. Remember, C1 has a posterior arch and an anterior arch, so I start there. So C1, 2, 3, 4, 5, 6. So here's the spinous process of C7. So here's the vertebral body of C7. Here's the joint space, and then this is T1. So that's really, really nice. We like to include at least the top half of T1 if possible. So the patient is nice and centered in our collimation, but notice we have collimated in a little bit. I typically don't collimate inside to side too much just in case the patient moves at all, but this is really, really nice. So in addition to including all 7 cervical vertebrae, do you remember what other anatomy we see in a lateral C-spine? Well, if you said zygapophyseal joints, you are correct. So let me point those out for you. So in a lateral C-spine, we see the Z-joints between C2 and C7. And that is this black diagonal line right here. So there is the Z-joint between C2 and C3, between C3 and C4, etc. So here's one, here's one. Here's another Z-joint right here, and then right here, this is the Z-joint between C7 and T1. Remember, you will not see the Z-joints between C1 and C2 in the lateral. Notice there's no diagonal line here. Remember, you have to do the AP open mouth to visualize the Z-joints between C1 and C2, and we'll look at that picture in a little bit. Okay, very nice. Next, let's look at our swimmers. So let's say we do the lateral and for whatever reason, we are unable to see C7T1. Maybe the patient's got really big shoulders, maybe they were unable to relax their shoulders, maybe they couldn't tolerate sandbags. In any case, if we can't see C7T1, we need to do a swimmer's. So you are going to keep the 12 by 10 portrait collimation, and you're still going to use 72 inches SID because they're still in a lateral position and there's a lot of oid here. This time, however, you're going to center lower. You're going to center approximately T1. So remember, for the lateral, we center at C4. Now we're centering at T1. So notice you can see the central ray right here. We're kind of skimming the shoulder. So the goal is to really penetrate through that thick upper shoulder region. A typical technique would be 100 at 77, but remember that's going to vary again depending on your patient and your equipment. So I want to reiterate, we don't do a swimmer's with every lateral C-spine. It's only if needed, okay? So how do we know we're correctly positioned? Well, again, the patient should be in a left lateral. You're going to this time ask them to raise their left arm and drop again that right shoulder. And the purpose is to separate those shoulders again so that we can visualize that spine a little bit better. So if you look at the x-ray here, you can see here's the left arm. It's elevated or raised, and then the right arm is down. And then we don't have to include the top of the C-spine. We got that in our lateral. But in this case, you can see that C1 is here. So C2, 3, 4, 5, 6. So C7 is right here under the clavicle. And then this would be T1. So, you know, your main goal is to separate the shoulders and then make sure there's no motion. Make sure the patient's nice and still so that the radiologist can adequately visualize that C7T1 region. Okay, good. So after the swimmers, then we're going to do the AP. So again, we're going to do our standing. You could certainly do this on the table in a trauma as well. But we're going to move into 45 inches SID this time. We're not dealing with all that oid, so we can move in and use a closer SID. Remember, our manufacturer in our lab recommends 45 inches SID, but you may be using 40 out at clinicals. You're going to keep that 12 by 10 portrait collimation, and you're going to center again at C4 and mid-sagittal plane. So if you look at this picture here, we're kind of looking for that Adam's apple region for C4. Average patient is about 10 mass at 70 kVp. If I didn't mention this earlier, you are trying to position the cervical spine over the center cell. So this technique may vary depending on your patient's body habitus. Now, we do need to add a 15-degree cephalic tube angle. And actually, I'd like to go back to our lateral to discuss why we need that tube angle. So if you look at the curvature of the cervical spine, notice there's this slight curvature. And remember, that's a compensatory curvature. We're not born with that. That develops once we're able to hold our head up as an infant. And typically that starts about 6 weeks of age. In any case, because of that curvature of our C-spine, our vertebral bodies are angled slightly inferiorly. So guess what? So are our intervertebral joint spaces. Well, we want our central ray parallel to our joint spaces so that we can see through the joint spaces very nicely. So imagine if we had a horizontal central ray, it would not be parallel to the joint space. But if we add 15 to 20 cephalic, now look, we can skim right through those joint spaces. So that's our goal. So let's go back. So always add 15 to 20 cephalic, and that's so that your central ray is parallel to your joint space. So how do we know we're correctly positioned? Well, as I mentioned, your tube angle places the central ray parallel to the vertebral disc spaces. You see that really well on the lateral. But the goal here is to visualize C3 through C7. So when I'm looking at the AP, I like to start at the bottom and count my way up. So notice this is the first rib. So this has to be T1. So 7, 6, 5, 4, and this is 3. So you will not see C1 and C2 on this projection. We're going to do those or visualize those better in the AP open mouth. This is a really pretty x-ray. I like the collimation side to side. The patient is nice and straight. We've included a right marker. I think the one thing we could do better here is notice how this mandible is overlying part of C3. If you notice the model here, she's looking straight ahead and her mandible, her jaw is raised. Now I don't want you to exaggerate it, but slightly raise that chin so that it's not overlying C3. So that would be the one suggestion to improve this radiograph. Otherwise, it's very nice. All right, next we're going to do our obliques. And you're going to keep your 12 by 10 portrait collimation, your 45 inches SID. You are still centering at C4. We're going to keep our 15 degree cephalic tube angle as well. All we're doing here is rotating the patient 45 degrees into an oblique. And we're always going to do both obliques for comparison. Now, remember, when we do oblique C-spines, we are visualizing the intervertebral foramina. Notice this patient is in an LPO. So when you position your patient in posterior obliques, you are seeing the foramina away from the image receptor. So if this patient's in an LPO, we're seeing his right foramina. This patient is in an RPO, we're seeing their left foramina. So you're always visualizing the side away from the image receptor. Now you could do, notice this patient's in a posterior oblique, you could do anterior obliques, but then you would need a caudal tube angle. So since we already have our cephalic tube angle on, let's just do posterior obliques. It's just a little less work, right? So let's take a look at our x-ray. These circles right here represent the intervertebral foramina. Now, you could mark the side closest to the image receptor as they've done here. So the patient's in an LPO, use a left marker. For the RPO, use a right marker. Or I think you could make a good argument for marking the side you're visualizing. So in this case, we'd put a right marker because we're visualizing, or excuse me, a left marker because we're visualizing the left foramina. In this case, you could use a right marker for the right foramina. Honestly, just be consistent between both projections. We always do both, remember, for comparison. And you can always annotate now in your digital equipment your position, LPO or RPO. Okay, so if you have any questions about the oblique, let me know. Big takeaways from this slide. We're going to do posterior obliques, 45 degrees of obliquity, and we are looking at the intervertebral foramina away from the image receptor. So an LPO shows us right foramina, an RPO shows us left foramina. Because remember, we have foramina on both sides of our spine, okay? Okay. Next, let's talk about the odontoid. So this is also called the AP open mouth. Now, we're going to begin with our portrait collimation, but I'm going to suggest that you collimate down to avoid exposing the orbits and even the thyroid. So your collimation is going to be smaller than 12 by 10 here. You're going to keep your 45 inches SID, and your central ray should go right through the patient's open mouth and mid-sagittal plane. An approximate technique for an average patient is going to be about 15 at 70. Remember, you're going to be over the center cell though, so your AEC will help you with that. So how do you know you're correctly positioned? Well, the base of the skull and the top teeth should be aligned. So top incisors, that means your top teeth. And those should be superimposed. So let me show you. Do you see this line right here? And it kind of extends over here. That's the base of the skull, so in the back. You want the base of the skull lined up with the top teeth. Okay, and I will show you how to do this in lab. But when those two things are superimposed, it allows us to visualize the dens really nicely. Especially in a trauma situation, you want to make sure you can see that whole dens very nicely. We also see the zygapophyseal joints in between C1 and C2. Remember, we'll see the zygapophyseal joints between C2 and C7 on the lateral projection. So, if we spend a minute looking at this diagram, remember this is C1, the lateral masses of C1. Remember in C2 through C7, that chunk of bone is called an articular pillar. This would be the inferior articular process or surface of C1, meeting the superior articular process or surface of C2, and then the space in the middle is that zygapophyseal joint. So just real quickly, when you're doing this projection, you want the Z joints to look symmetrical. So we want to see the dens and the Z joints. If your patient has any tilt or any rotation, it can make those joints look asymmetrical. And we want to make sure we're not confusing that asymmetry with a possible injury. So be very detail-oriented, very precise when you're doing this projection so that you don't inadvertently cause asymmetry of those Z joints. Also notice, you see this line right here? So that patient has a permanent retainer behind their upper teeth, in case you were wondering what that is. Okay, perfect. Next, let's transition to lumbar spine. And remember, we're going to talk about T-spine and sternum and ribs in the next unit. So lumbar spine, we're going to do ours recumbent on the table. Many physicians like this projection standing though. But again, we're going to do ours recumbent just to kind of simulate an injury. So you're going to use 17 by 14 portrait collimation. And we'll talk more about collimation in just a minute. You are going to use 45 inches SID in our lab. Remember, out at clinicals, you may be using 40. And you are going to center, or our textbook recommends you center, at crest and mid-sagittal plane. But let's talk about that for a second. Do you remember which vertebral level iliac crest corresponds to? Well, if you said L4 or L5, you're correct. So we have 5 lumbar vertebrae, right? So I would suggest you center closer to L3, which is the middle of the L spine. Our textbook suggests you center closer to the bottom. And while that's fine, I think if you center up a little bit higher, you get a nice symmetrical or centered picture of the lumbar spine. If you look here, you want to make sure you include half of T12. Okay, so again, if you center a little bit above crest, you'll ensure that you include T12. So what I do is I go 2 fingers above crest. Okay, so that's just my trick. I like to center closer to L3. I just think it makes a nicer picture. Also, so you want to count to make sure that you've included all 5 lumbar vertebrae. Well, if you include half of T12, then you can see your ribs, right? So if there's a rib here, this has to be T12, L1, 2, 3, 4, and 5. Okay. Notice we've collimated inside to side. You want to make sure your patient's nice and straight, again, so there's no curve in the spine caused by our positioning. And then you want them to hold their breath to prevent any motion or blurriness. So again, I recommend 2 fingers above crest and mid-sagittal plane, but certainly when you're taking your exam, your textbook is going to ask you where you center, and you're going to answer crest for the exam. But clinically, I think two fingers above is nice. The oblique lumbar spines. So again, we're going to do 45 degree obliques, and we're always going to do bilateral obliques for comparison. So you're going to keep your 17 by 14 inch portrait collimation, 45 inches SID, and look, this time your text recommends centering at L3, so about 2 fingers above crest. Also, you are going to center 2 inches medial to the upside ACES. So if you look at this patient, they are in an LPO, so you're going to find the right ACES and center 2 inches medial. Okay, so L3, which is 2 fingers above crest, that's where this line goes. And then this line goes 2 inches medial from the upside ACES. All right, so 15 at 75, again, that's approximate, depends on your patient and your equipment. By the way, you could do this standing as well. A lot of orthopedics are going to request this standing, but we're going to do ours on the table. All right, so in the oblique lumbar spine, do you remember what we are visualizing? Well, we are looking for the zygapophyseal joints, and we are looking for the presence of those Scotty dogs. And that Scotty dog is just a radiographic sign that we've included the Z joints, or that we're visualizing the Z joints. So this is the opposite of the cervical spine obliques. In the cervical spine obliques, remember, you saw the side away from the image receptor. In the lumbar spine obliques, you're seeing the Z joints closest to the image receptor. So in other words, if this patient's in an LPO, you're seeing the left Z joints. If the patient's in an RPO, you're seeing the right Z joints. So here is a nice, beautiful example of lumbar spine obliques. So I'm gonna trace a Scotty dog for you. So here is the ear of one dog, the nose, and then the front leg. Okay, I don't really care about the back half. I want you to focus on the front half of the Scotty dog. Here is the eye. Remember, the eye is the pedicle. So the Z joints, look at these black horizontal lines right here. Those are your zygapophyseal joints. So remember, it's where the ear of one dog meets the leg of the dog above. Okay, so it's the inferior articular process of one vertebrae meeting the superior articular process of the vertebrae below. And that's what makes your Z joints right here. Okay? So typically, again, I think I mentioned this already, but you'd always do both obliques for comparison. In lab, you can just show me one. That's fine. But I do need you to know that an RPO shows the right Z joints and an LPO shows the left Z joints. Okay? All right. The lateral lumbar spine. So you are going to turn the patient onto their left side, or if you're doing them standing, you're going to position them in a left lateral. We're going to use 17 by 14 inch portrait collimation again. You can collimate in side to side if applicable. Keep that 45 inches SID. Again, your text recommends crest and mid-coronal plane. I still go a couple fingers above crest. I like L3 a little bit. I just think, again, it centers our anatomy better on our image receptor. And this time we're going to use a little more technique because we're really penetrating through a thick body part. So 40 at 81 approximately. So how do we know we're correctly positioned? Well, a couple things. First, they're in a left lateral, so we already talked about that. You have to make sure you include all 5 lumbar vertebrae. So in a lateral, I like to start at the bottom, at the sacrum, and count my way up. So here's sacrum. So 5, 4, 3, 2, 1. Okay, so this would be, I see a rib coming off here. Oh, right here. So this would be T12. So 1, 2, 3, 4, 5. Again, it can be a little bit confusing at the top with the presence of the ribs. So I like to start at the bottom. In a lateral lumbar spine, in addition to the 5 lumbar vertebrae, we're also looking at the superimposed intervertebral foramina. So that is these circles right here. And I say superimposed because you have intervertebral foramina on the right and you have intervertebral foramina on the left. We know that, right? But when you're in a lateral lumbar spine, the right and left are superimposed. So it should look like one foramina. Okay? Really, really nice. One other thing, if you notice when the patient is recumbent, sometimes when the hips are a little bit wider than the waist, it can cause that spine to sag a little bit. So you can include a sponge under the waist to kind of straighten out or stabilize that spine. You don't have that problem when the patient is standing. It's really only an issue when they're recumbent. So consider that. If the hips are significantly bigger than the waist, you may want to support the waist with a sponge. Also, this black strip here, we're not really using these anymore, but that is a lead strip to capture scatter radiation before it reaches our image receptor. This is a really thick body part, and we're using a lot of technique, so there's a lot of scatter with this projection. That black strip there is meant to capture the scatter, again, before it reaches the image receptor. Now, we're not using these with digital receptors as much anymore, but I just wanted to point that out since it was in our picture. And because this is a left lateral, we're going to include a left marker. Okay, the L5-S1 spot. Now, if we can go back a slide, we can see L5-S1 very nicely on this radiograph. So some departments, if you can see L5-S1 nicely on the lateral, they won't do a spot. But there are times where if the patient's got thicker hips, it's difficult to see that L5-S1 region. Then you would do what we call a spot. And it's basically a collimated picture of that L5-S1 region. So I say 12 by 10. You could collimate down a little bit if you wanted to. We're just really looking for this whole L5 vertebrae and then the top of the sacrum. 45 inches SID. Now, where do you place your central ray? Well, you're going to be 1.5 inches below crest, so find crest, go a little less than 2 fingers below crest, and then you want to be 2 inches behind ACIS. So about 1.5 inches below crest and 2 inches behind ACIS. That is where you're placing your central ray. And I'll show you how to do that when we get in lab. Now, you do need to add a 5 to 10 degree caudal tube angle. And if you notice, when the patient is recumbent, the line between iliac crest, between the pelvis here, right and left, is not perpendicular. So to compensate for that, you want to include a caudal tube angle, 5 to 10 degrees. So how do we know we're correctly positioned? Well, you should see the L5-S1 joint space nice and open. You do want to include, as I mentioned earlier, all of L5 and the top of S1, and that joint space should appear nice and open. If you forget to add your tube angle, a lot of times that joint space won't appear nice and open. So if your joint space isn't open, consider adjusting your tube angle. All right, let's talk about sacrum and coccyx, and then we'll be all finished. Okay, so when we do lateral sacrum and coccyx, we're going to do it all on one image, which is nice. We're going to use 12 by 10 portrait collimation, and we're going to include the entire sacrum and coccyx, so that's nice. Use 45 inches SID, and where do you center? Well, you are going to center 3 to 4 inches posterior and 2 inches distal to the ACIS. So let me say that again. You're going to find ACIS. You're going to center 3 to 4 inches behind ACIS and 2 inches below ACIS. And I will help you find this when we get into lab. Remember, you can also use your L5-S1 joint space as a reference too. So the patient should be in a left lateral. We're doing all of our spines in left laterals. And again, you want to include the entire sacrum and coccyx. So the top of your image receptor should be at L5, and again, all the way down to the tip of the coccyx. Okay, and then let's look at AP sacrum and then AP coccyx. So the AP sacrum, again, the patient is now laying on their back recumbent. We're going to use 12 by 10 portrait collimation, 45 inches SID, and we're centering 2 inches above pubic symphysis and mid-sagittal plane. When you do a sacrum, you want to add a 15-degree cephalic tube angle. And if we go back a second, it is to compensate for the curvature of the sacrum, right? So if we used a straight horizontal or vertical central ray rather, it would not be perpendicular to the bone. If we add a cephalic tube angle, now our central ray is perpendicular to that sacrum. So how do we know we're correctly positioned? Well, you need to include the entire sacrum, all the way here. So notice SI joints on both sides, and then we've included the fifth lumbar vertebrae as well. And this is kind of a grainy picture, but I usually put my right marker in the bottom corner. And then I do have my patients hold breath just to prevent motion. Let's look at the AP coccyx. So it's the exact same positioning, 2 inches above pubic symphysis and mid-sagittal plane, same collimation. The only difference here is you're adding a 10-degree caudal tube angle. And if we go back a couple slides, that's to compensate for the curve, kind of the anterior curve of that coccyx. So sacrum is 15 cephalic, coccyx is 10 caudal. And hopefully, when you do your 10 caudal, it separates the coccyx from the pubic symphysis. So your job is to include the entire coccyx, and it should not be superimposing that pubic symphysis. Okay, but otherwise the centering is exactly the same, 2 inches above pubic symphysis. So this concludes our presentation. I'll go over all of these positions with you in lab, and certainly if you have any questions, let me know. Thank you.